tremendous growth of that neuron stimulated with BMP. Now we have, even though we're able to culture these and make them grow, making them grow in the right direction and the right spot and attach is a very complicated issue. There are a lot of development in stimulating the axons to the proper target. The axons have growth cone tips and the molecules on the leading tip that when they are released, they can actually adhere to a proper tissue, and they can also repel in proper directions. And that's what we're trying to understand, how to demonstrate or how to provide the proper channel for it to go into. And that's where bridging the gap, if you've got a complete transection of bridging that gap, there's been a lot of talk about friendly scaffolding of a damaged cord. Now, there's been a lot of nice studies on the tubes packed with Schwann cells, olfactory cells, which are an ensheathing glial cell, and being able to create neurons to grow through that. Fibroblasts are a problem. They grow rapidly. Recent evidence has shown, and we've done some of this in our lab, that we can change that fibroblast and try to genetically transform it into a good cell. If it grows so rapidly, why not try and take advantage of it? We have genetically altered some of them to produce the neurotropin 3, and has given some partial growth of axons, but there's a long ways to go when we talk about that. Transplant, lost cells, fetal CNS tissue, quite controversial area, but there are some exciting results in animals. Timing of reduction or spinal cord decompression. Again, a very controversial area. Some of the information from our lab. Several years ago, we did a study on 30 beagle dogs. We constricted the spinal cord, 50% constriction. All dogs were completely paraplegic. We squished it enough. This was the constricting band we utilized right there and squished. Here's the cord coming down. This is caudad. This is cephalad. And we squeezed that down to 50%, measured this accordingly, and got complete paraplegia in all these dogs. We decompressed them. We removed that band immediately in 6 dogs. That compression wasn't there. Probably took us 10 seconds to get it off. We then left that band for 1 hour of compression in 6 dogs. We did 6 hours of compression in 6 dogs. Left the compression for 24 hours in 6 dogs and up to 1 week in 6 dogs. A very similar protocol that we used for the cauda equina research done a few years prior to that. Here's the results. If you left, here was the initial somatosensory evoked potential of that spinal cord before compression. Post-compression, immediately ran 1 set, and it was always flatline. Now, if you waited 6 weeks after decompression, we left this for 6 hours, and then did the post 6 weeks later. There was absolutely no recovery if you left that compression for 1 week. Here's a dog that had 1 hour of compression, then we immediately decompressed it. Immediately post-compression had complete flatline, but 6 weeks after compression you can notice the tremendous recovery of the somatosensory evoked potentials. Here was the immediate decompression. You can see the evoked potentials were pretty much absent. Here's how they recovered. If you immediately decompressed or up to 1 hour, we had statistically significant improvement in the somatosensory evoked potentials, and neurologically these dogs all recovered. Now, if you left it for 6 hours, 24 hours, or 1 week, there was no statistically significant improvement in the evoked potentials, and all dogs remained paraplegic. Here is a dog that had 1 hour of compression. This was 6 weeks later, and you'll notice there is some central necrosis, but notice the normal, fairly normal tissue around it. This was a dog that did recover, even though it had quite a bit of spinal cord tissue injury. This was a spinal cord, and this was about a centimeter above the actual compression. This had 6 hours of compression. You'll notice the entire spinal cord has basically is necrosed. So if you left it over 1 hour, we saw almost complete necrosis of that cord. Here's an electron micrograph showing an actual neuron. Here's the axon coming out. And this is in 1 hour. Pretty good, or 6 weeks after 1 hour of compression, then decompression. Pretty good continuity of that axon. Now here was 6 hours. If you got up close on electron microscopy after 6 hours or 1 day or 1 week, complete loss of all the organelles. There was complete necrosis inside that cell. So in this animal model, decompression in 1 to 2 hours may allow some element of recovery. It certainly did in the dogs, and I think we've all had anecdotal experiences. I've had 2 cases of complete dislocation of the facets that they come in immediately to the or not to the operating, but to the ER. We had one right on campus at UCLA about 8 years ago. Fell out of a fraternity, had a C5-6 complete dislocation, completely quadriplegic, and he reduced, the second he got laid on the table with tongs, he reduced completely, and he immediately noticed return into his hands. And I know you've had one or two cases of that up here. Paul Anderson always would talk about that. That immediate decompression may have some benefit, and I think that fits in with this animal model. So there appears to be a window of opportunity in some of these individuals. It doesn't mean it's going to work on anybody and everybody, but we don't know the damage of that spinal cord until you decompress them. So I tend to be on the side of, gosh, if you don't know, why not do it sooner than later? Show you one final case. This is actually the start of the Miami project. This is Nick Bonaconti's son right there, drops his head, bam, hits with the top of his helmet. It's a C4 quadriplegic. Early on, what could you do? This is what you can control right at the scene. Give these people oxygen. You get to their emergency room. Watch their blood pressure. Regardless of chemicals, these are things that we can control, oxygenation and blood pressure. Prefer to do most of these anteriorly to get the decompression. Here's a corpectomy. In that case that you just saw, and you can see the traumatic, that's right down on the dura, pretty well banged up. Iliac crest bone graft. Prefer to use plates with all these and stabilize them, and hopefully allows us to not have to use halo support for many of these. Post-operative x-ray. For the sake of time, I will conclude here with this diagram. This is a very complex area. There are a lot of things involved, many different cells that all have an impact on spinal cord. There are a few things we can control that we have mentioned, but it's a very complex area that we are continuing research in, and hopefully over the next decade we'll make further progress. Thank you.
So what we're going to talk about, and give you just half the talk, is that neuroregeneration is probably where we're heading with spinal cord injury over the next 25 years. There have been a tremendous number of advances as far as imaging, as far as initial management of spinal cord injury, as far as we heard this morning, going and seeing who's actually had a fracture, as far as rehabilitation. They're really where the advances have been. There's been some slight advances, again, with methylprednisolone about maybe reducing secondary injury, especially with incomplete spinal cord injuries. But what the future is going to be is to overcome the really substantial blocks there are to be able to have a functional recovery, especially for a complete spinal cord injury. And some of these blocks include the body's response. The fact is that nerves, especially in the central nervous system, do not regenerate well. The second thing is that there's usually cysts or cavitation and with eventual scar formation, and these also serve as blocks. And what's happened is I had a list that showed about 150 different substances which are currently being investigated by a variety of different drug companies to see if they can go and somehow have the holy grail of achieving a cure for spinal cord injury. What happens is the cost to society of spinal cord injury in the United States is, including both direct and indirect costs, about $40 billion a year. So there's really a huge incentive towards trying to have this done. And these are some of the different things that are being done: neurotropic factors, cellular bridging, growth cone stimulation, and ways to inhibit myelin. I'm going to briefly touch on a couple of these elements. Probably one of the biggest factors which inhibits neural regeneration is the effect of myelin. And myelin itself contains a substance or a group of substances called neurite inhibitory epitopes. And these create an inhibitory microenvironment. And what happens is, mature adult organism, you don't want a bunch of new nerves going and short-circuiting things. So that in general, this is a positive effect. But when you have a spinal cord injury, this is one of the major inhibitors towards the axons respouting and regrowing. And there is glial scar formation, which also inhibits regeneration. And finally, there's an absence of Schwann cells, which you have in the peripheral nervous system, which guides nerves along and allows regeneration to occur. And finally, in the area where there has been an injury to the spinal cord, there are limited growth factors involved to help achieve the growth. And this is just something for a study. And what happens is that people think of a nerve, and you look at the basic biology textbook and you have sort of a cell body and you have one little axon growing out. The fact is, it is a hugely complicated thing with multiple areas that are sprout and grow, with multiple cells interacting, and it's very difficult to have things grow in the right direction. Now, as mentioned, myelin causes inhibition of axonal regeneration, and these inhibitory factors are due to one specific gene. And it's a hope to be able to go and either use antibodies against these factors or ways to shut down the gene to go and to help the body to regenerate. And one of the recent studies has used monoclonal antibodies against these neurite inhibitors, and what they found in animal models is improved cortical spinal growth. Another way to potentially go and improve regeneration is to reduce scar formation. And there's been several different ways to look at this. One thing that they went and done is that they found that if you go and you completely remove the glia themselves, that CNS axons will go and regenerate readily. Finally, there are different proteoglycans that go and inhibit growth, and by using something like urokinase, they've also found in an animal model a way to go and improve axon regeneration. Now, it's one thing to be able to go and allow some growth, but what happens in general, even these different things where they've gone and inhibit the scar formation, usually after several millimeters, the nerves begin to peter out. So another track to go and try to improve neural regeneration is to use neurotropic factors. And some of the ones that are being currently investigated include brain-derived growth factor, neurotropins 3, and neurotropins in the category of 4 and 5. And again, in animal models, it's been shown that with intrathecal installation of some of these growth factors, you've had increasing axonal growth. Finally, another area is that it's been shown in the peripheral nervous system that by cutting a nerve, you can generally go and get some type of growth. And it's been shown years ago that if you go and you implant part of a peripheral nerve into the spinal cord, you can have some axonal growth into the peripheral nerve itself. And what happens is Schwann cells provide channels for the axons, and these Schwann cells also go and produce a number of the different nerve growth factors that can go and promote this type of regeneration. And what they have shown that by one study where they used multiple small intercostal nerve grafts to go and span a section of spinal cord which has been transected, that they got functional recovery. So this is another tact where there is some evidence that can be done. Finally, I think what everybody hears the most about is the whole stem cell issue. And what it's shown is that fetal tissue transplants have been shown to go and promote axonal growth, again, due to improving the environment, and has improved host neuronal survival. So, for example, with an incomplete injury with immediate implantation of fetal tissue, they've had improved survival of the at-risk neurons. There's been a case report of human fetal tissue being induced into a syrinx and has eliminated that syrinx. And finally, stem cells have been planted into injured spinal cords of rats with improved motor function and differentiation both into neurons and to glial cells. So in conclusion, the spinal cord injury is a relatively common problem, and it's got a massive impact on society, and that's why there's so much investigation going on. There are promising researches going on, but from at least what my interpretation is that there is no one thing. There's no one silver bullet that's going to go and cure spinal cord injury, at least in the short term. What I think is that in the very short term, there's going to be several new neuroprotective therapies, things that are going to improve upon the effect that we get with methylprednisolone. So what I think is a combination of the use of neurotropic factors, cellular substrates, and scar inhibition, combined with some type of grafting will probably be, this combination will markedly improve what we are currently doing for spinal cord injury. Thank you.